I'm Jacob Friedman. I'm an orthopedist here in Shelby at Shelby Bone and Joint Clinic. I'm here to talk about the anterior approach to total hip replacement today. Hip replacement is a very successful procedure folks have been using for treating hip arthritis and chronic hip pain for many years. Since about the 1960s, it's been very commonly used. There are about 300,000 people a year that undergo hip replacement in the United States at this point. The traditional way to do a hip replacement is to make an incision on the side of the leg and open up the joint where we replace the ball and the socket to create a new joint that has smooth, new metal and plastic materials that can take the place of the old worn-out joint. In a way, it's kind of like replacing the tires on the car when they're worn out. The anterior approach to hip replacement is something a little bit newer in the United States. Although the technique was first used in the late 1940s in France, it hadn't really caught on until later in the 80s. In the United States, it really didn't catch on until the late 90s, and it's been used here for about 15 years very successfully. The advantage of the anterior hip replacement compared to the more traditional techniques that we've been using is that we do a little less damage to the muscles on the inside of your body around the hip than we did the old way. The more traditional hip replacement is still very successful and commonly used, but it requires that we either cut some bone or some muscle off of the areas around the joint, and this requires a little bit longer time for healing and recovery and some restrictions in how you can use your leg after surgery. The anterior approach to hip replacement uses a smaller incision placed a little bit more to the front of the hip rather than the side or the back, and this allows us to use an area between muscles rather than having to remove them from the bone. By not removing the muscles, we can leave them in place. It allows for a faster recovery. We can still get into the hip joint and access it and replace the ball in the socket the way we like to, but it means that we don't have to keep the same kind of restrictions on you when you're done. We let you get back on your feet right away and don't tell you don't move or don't bend or don't twist this way. We just let you get back to doing your normal activities, tying your shoes, picking something up off the floor, rolling over in bed, using a standard commode, getting in and out of the car. Really nothing that we have to be particularly careful about. By being able to spread the muscles rather than remove them from the bone, it also makes the hip a little bit more stable in the early phase after surgery. An additional advantage of the anterior approach to the hip replacement is that during surgery, we have you lying flat on your back in the operating room. By having you flat on your back, we're able to use x-rays while we're working, and this helps us to align the implants in the body a little bit more accurately than we could do in the more traditional techniques where most of the time we had you on your side. There are some other small advantages to having you on your back, which gives us a little more option and flexibility with the type of anesthesia we use. But really the biggest things that are advantages are that we can do less damage to the muscle and the tendon around the hip. We can expect a faster, smoother recovery, and we can really limit the degree of restriction that you have to have. We'll get you back to your regular activity right away. Hip replacement is now commonly used for end-stage arthritis. The most common form is osteoarthritis. This is where the hip simply wears out, just like the tread on your tires wears out from overuse. There are some other more mechanical causes. There could be some chemical causes. Certain other types of arthritis, like rheumatoid arthritis or psoriatic arthritis, can contribute to need for hip replacement. And there's also a condition called avascular necrosis, which you'll hear a little bit more about from Tony Sosebee, who recently underwent hip replacement for this condition. Avascular necrosis is essentially when the blood flow into the ball dies or is damaged and the ball dies and it collapses and is no longer round. The ball doesn't fit in the socket well and arthritis develops. At the end stage is that the joint is worn out and we do a hip replacement. By doing a hip replacement, we essentially take a stem of some kind, and this is an example of what Tony has. It's a metal stem that fits inside the upper part of the thigh. We have either a metal or ceramic ball that fits on top of that to replace the ball component of your hip. And then we replace the socket part with a metal shell and usually a plastic liner. And we now have a plastic bushing with metal that rotates in any direction your hip needs to move, nice and smooth. By using this anterior approach, it gives us the advantage of optimizing the position that we place the cup and the ball at the time of surgery to lower any chances for leg length inequality, for dislocation risk, for stability purposes. I have a little sample here of the same kind of thing just an acrylic mold of what half of your pelvis might look like, the bones of the edge of the pelvis, the wing of the pelvis, the ischium, and then a sample of the socket in place, and the stem inside a little plastic representation of the upper part of the thigh. And once again, it shows that we can rotate the hip, we can abduct it, flex, extend it, and the hip moves smoothly at this point. So a typical hip replacement operation, we have you come into the hospital through our Joint Academy on a Monday, maybe a Tuesday, and spend 2 or 3 days in the hospital. The first day is the surgery day, and essentially just some recovery time, getting over the anesthesia and recovering through the pain. We have a variety of techniques we use to minimize the pain you have. And again, an advantage of this anterior approach is the smaller incision more towards the front seems to have less pain, less scarring. The incision's in an area that doesn't seem to be near your backside where you're lying on it or sitting on it when you're in bed. And then the next morning we get you out of bed and start working with physical therapy, up with a walker, as much help as you need. And usually within a day or 2 or 3, we have you walker, maybe a cane, and moving comfortably, some pain pills to help get by with the pain, and out of the hospital on your way home. So hip replacement is commonly used for folks with arthritis. It's generally done in folks that are over 50, although there are some indications for younger people. Anyone could be a candidate for an anterior approach to the hip replacement. There are some technical challenges depending on someone's physical size, muscle tone, but anybody could potentially be a candidate for an anterior approach to their hip. The majority of people are finished using a cane within a couple of weeks of surgery, and almost everybody is back to 100% within 2 or 3 months from surgery. While hip replacement is a very successful operation, we certainly try to do everything we can to avoid a hip replacement first. Sometimes it's the only thing left that we can do, but in the meantime, we try to use all of the other non-surgical techniques we have available. Exercise, physical therapy, Tylenol, anti-inflammatory medicines, use of a cane or a walking aid. But at some point a hip replacement may be necessary because the pain in the groin and the pain with standing or twisting or rotating has gotten to the point where it interferes too much with your normal daily life, and we need to have another choice. You'll be seeing Tony Sosaby, and even though he's fairly young for a hip replacement patient, he had avascular necrosis, which does seem to affect a younger population through a variety of possible risk factors. He'd lived with his symptoms for a long time, not really knowing exactly how bad things were, with both hips involved, and after struggling with difficulties with work, with daily life, limiting some of his normal activities, he got to the point where the pain in his groin and his hip was so severe that he approached me. We talked about his options, and while nervous about surgery, he tried to get back to work and continue using some pain medicine and use of a cane, and the pain just became too great over the time that I had known him, and we got to the point of hip replacement. He did very well the first time, and thought that with how well he was doing, he might be able to return to work, and hadn't realized how bad his other hip was hurting as well. By the time he tried to get back, realized again that Motrin, Tylenol, pain medicine, using a cane, limiting his activity, he was just to the point where he was essentially sitting in a chair or sitting at a desk, and he wasn't able to get outside, check his mail, work in his garden, walk around at work, stand for any extended period of time to be able to do what he needed to do. And we pretty quickly proceeded to doing his other hip replacement, which has also gone very smoothly and has allowed him to get back on his feet and be more active than he has been in a long time.